Hello, Andrew Kolsky from Stop My OCD here. And today we're talking with Bernita Oakes. Bernita is a resident in counseling in the state of Virginia, and she has some experience working with OCD cases. So, Bernita, why don't I give you a chance to introduce yourself?
Hi, well, I'm Bernita, and I have been a resident now for about 2 years, and I see all types of cases, trauma, anxiety, depression, OCD, and only work with adults. And yeah, that sums it up. Pretty good.
Great. Well, we really appreciate you taking the time to share your experience here because other counselors, students, residents who might be considering working with OCD patients are they don't really have a whole lot of information to draw from. And I'm hoping that through these videos and experiences, they can at least make an informed decision as whether this is a field for them or not. Um, so to start off with, then, can you share with us what got you interested in working with OCD patients in the first place?
Well, it's interesting because that one kind of fell in my lap. I had been given a client who came with a generalized anxiety diagnosis, and from a previous like psychiatrist and practitioner, and yeah, like we did work for about a year, and it was CBT, ACT, lots of mindfulness, um, and it may have like subdued it a little bit, but it just kept. It was just still there, and yeah, it wasn't until I actually saw your presentation to our practice, Andrew, um, that it clicked with me that this client has OCD, and it's because it wasn't the typical like contamination OCD that you see in like all the movies and everything like that. So it was so eye opening and amazing, and we've done a lot of work since then. So that's kind of how it started, and then I started to see it in some of my other clients too.
Yeah, that's really interesting because it's exactly the same story that I tell, which is I didn't know anything about OCD, and I had a client one day, and just something struck me about it, and I started to look into it. And as I started to learn more about it, I realized, oh my gosh, I actually had all these prior clients who had OCD, but I had no idea. And then I felt, it's like, wow, this is really like, how did this go on? How did I miss this? And then as you talk to counselors in general, whether they be mental health counselors, whether they be psychiatrists, psychologists, people in the field, um, it seems that OCD is quite often missed or misdiagnosed, and the patient will get a diagnosis of generalized anxiety or something like that, which is just not the right diagnosis. Um, so with that, I tell people when I was in school, I really didn't get any training on OCD at all. I had no former knowledge. I had no idea. What was your experience like? Have you learned anything about OCD in school or any other programs?
No, I mean, it was the same as yours. Like, we of course talked about OCD and diagnosis class and all that, but it was never not to the level of like, you know, just your typical things like contamination, checking. It was mind blowing. It really was mind blowing to see the presentation that you gave because it really broke it down, and I wish I had had that in school
Hmm.
because, like you said, I feel like I could have helped more people. So
Yeah.
so
Well,
yeah.
you've mentioned about the fact that OCD is not just contamination or somebody washing their hands, which is the typical thing we think of because I guess that's what we see on TV or the movies or something when we hear about OCD. But there's so much more to it, and there's people who even have mental compulsions, which is maybe they worry excessively about a certain thing or they ruminate about a certain thing. and they're not doing any outward action at all as a compulsion. And with that, in my experience anyway, that causes even more confusion for practitioners who are not trained in OCD, because they don't know what that is, and they miss it, and they say, well, if the person's worrying a lot, it's got to be generalized anxiety, and it's actually not, because they're worrying as a compulsion based upon this obsession that they're dealing with. So yeah, it's the more you dig into it, the more interesting it becomes. Um, so, in your experience, once you started actually recognizing OCD and then working on it, what is your feeling? Do you think patients can actually be treated for OCD?
Yeah, absolutely. Just like most diagnoses, I don't know that they ever really go completely away, but it's coming to treatment is like giving you the tools, the toolbox. We start it for you as clinicians. We like help you get those tools and give you all of that. So when you do 2, 3 years from now move on and you get hit with like an obsession or compulsion, you can recognize it and use those tools on your own. You don't need us for the rest of your lives. So it's manageable, it's treatable, it's absolutely, yeah.
Right. I know one of the other things that I run into a lot is, when I'm talking to other counselors about OCD treatment, and when I talk about exposure and response prevention in particular, um, it's interesting to watch the reactions, because when you explain how exposure and response prevention works, that you actually have to expose someone to the stimulus that causes them this distress and have them sit with that distress. There's many counselors who just don't feel that they have the wherewithal to be comfortable themselves to do that, and they decide, this is not for me, I don't want to treat OCD. And then there's others who recognize how it works and that it's a part of the process, and they see the results on the other end, and they do like it. That's my experience. What would you say, what's for you as a practitioner, what's maybe the hardest and the easiest thing about OCD treatment?
I would definitely say the exposure. I am the first part that you described. The sitting with it, like I feel what the client feels. And it's really tough, but it can be extremely like powerful, and you're building confidence back from saying like I will not give in to this compulsion anymore. And to be a part of that is really amazing. Um, to be a part of that part. So that I would say the exposure part is the most challenging. I've been enjoying like the inference-based CBT with getting it in at the beginning part of the whole process. So understanding where the doubt comes from um, and getting ahead of it, kind of. Um, that part obviously is a little more comfortable than sitting right before you need to convulse. So, but it also lends itself to more of like my approach too. So yeah, but both I see value in all of it, and I think that's the important part is to understand the value in it, and that you know it can really help.
Yeah, and you mentioned inference-based practice there, and I actually have some other videos out that explain the difference between the types of treatments. You've got your inference-based treatment, like you said, that focuses on sort of before we even get into the OCD cycle, and then we've got exposure and response prevention, which focuses on when we are in the OCD cycle. And I actually, in my practice, I use both, because I think it's important to provide the best set of options that I can, and I find it to be really effective and helpful with my patients. Um, what about for you? Do you typically get patients that are strict OCD, or do you have people that have co-occurring disorders along with it? What has your experience been?
So far, I only have a couple of OCD patients, but the couple that I do have a trauma component with them. And, you know, with that comes some depression and whatnot. So, um, and that can be something that is something, right, Andrew? That like the OCD can come from trauma. Is that
Well, I often tell people, and even in the support group that I run, I tell them in my experience, I break OCD down into two basic main categories. The
yeah,
first one is someone who says, ever since I was a kid, I've always had OCD of some sort of an obsession about something. And then I have the patients who say, no, never really had anything. And then I had this traumatic event occur. And as a result of that, and that typically, in my experience, results in like the mental compulsions, the worry, the rumination, those types of things. Um, and then I'll have patients, like I have a couple right now who have had OCD ever since they were a kid, so they fall in that first category. But then we go and we start with treatment, and when we start the treatment, it becomes apparent that they have some outstanding trauma that's never been treated. It may not be anything directly related to the OCD, but
right.
I find that the OCD treatment is really um, it's hard to do it until you clear the trauma with the patient. And so we spend some time, we clear the trauma, and then they're more able to focus on the OCD treatment. So yeah, it's interesting. Everybody's unique.
Yeah, and I think that's it. Like that's like listening to you describe those. It's so cool because it is every single person is so unique in how they show up with these symptoms. So it's cool.
So when you are working with a patient with OCD, what is your goal? Like, what would success look like?
Really, just getting them the tools that they need so they don't need me forever. So they can handle this on their own in the real world, and feel confident about that too. You know, um, I think that would be my goal. I'd love to know what their goal would be too, but I imagine it might be pretty similar.
Yeah. Well, they're always going to say their goal is, my God, stop this distress, stop the feeling.
Absolutely, understandably.
um, so, another area that I think is important to talk about is many people with OCD are living with loved ones or caregivers, or, they deal regularly with coworkers, friends. What advice do you have for the loved ones and caretakers in a person's life when they're dealing with OCD?
I think it would be to get involved with treatment in the sense that they need to educate themselves as well so they know that they're not accommodating any compulsions or enabling. And it's in a lot of ways it's coming from a really good place. Um, but it can be detrimental to your loved one's treatment. They're trying to not do these things. So um, yeah, I think it would just be participate in it and really just try and understand. And there are a lot of like groups too. I think you actually have some groups for loved ones that you can come to and ask questions and just find that support for yourselves. I think that's like super important and really helpful for everybody in the family. It's just like with anything, right? Like addictions, like the whole family needs to be involved. Eating disorders, the whole family needs to be involved. Like these are communities, like we need to, kind of band around and help in a good way. So
Mhm. Yeah. um, I couldn't agree with you more, and we do certainly um, get a lot of questions from loved ones and caretakers in our support group. And I actually just recently put another video out there about a process that I've created called a comma don't, and it's a it's a 5-step process for caregivers and loved ones on how to address the situation when the person with OCD is looking for accommodation, but now you know that that's actually not helpful. How do you handle it? What do you do? Many people just don't know what to do. So this process just walks them through step by step. Here's exactly how to handle it. And so far, I've gotten nothing but really positive feedback from loved ones and caregivers when they have this outline, the structure of how to go about doing that. So um, yeah, it's definitely an interesting thing. Um, so different question here. What advice would you have for someone who believes that they have OCD, but excuse me, but is afraid to get treatment because they hear about exposure and response prevention and how it's going to be, they're going to have to face their fears. What advice do you have for someone who's considering getting treatment?
Well, for one, like I want to I would validate that person and say that I understand that OCD has been serving you, but there's something that brought you here, that it's not maybe as efficient, and it's exhausting. So as far as like treatment goes, you're not going to be alone doing this. We're not going to tell you this is the timeline. You are going to be a part of that process with us. And of course, we're going to challenge you in good ways, but only to your discretion and when you're ready. And it's a really brave and courageous thing to do, because it is something that it's something that served you for this long, even though it's hurtful and exhausting and everything. It's like the devil, um, and now it's trying something different is scary. I get that, but also like you said, Andrew, like if exposure therapy, you don't necessarily have to start there either. You can start with ICBT, and see if you can get ahead of the obsessive compulsive aspect of things too. So there's not just that one way. So if it's just that is holding you back, and know there are other options too, and that even with exposure therapy, there's so many steps before you even get to an exposure. We don't just throw you into the hot water. Like, we want you to feel safe and ready. It's scary still, but yeah.
Well, it's I realize this is your interview, but I because of what you shared, I wanted to share an experience that I had because it's so relevant to what you're saying. And this is certainly not the norm, but it is a real case. So I had a client who came to me for OCD, and we did the initial assessment. And yes, this client had OCD, and excuse me. And I typically will start off early in the process where I'll give the client some homework to track some of the obsessions and compulsions and things. And so I gave this client the homework, and I kind of explained what was going on. And you mentioned ICBT a couple times, which is the inference based CBT, which basically focuses on the front end pre OCD cycle. And so I try and offer homework that reinforces those ideas. Anyways, for this particular client, I give them the homework, and we have our next session scheduled next week. And next week comes, and we get on, and I'm getting ready to start actual treatment. And the client says to me, after I did the homework, it all kind of came clear to me, and I don't have that problem anymore. And I was shocked. It's like, well, wait, we didn't even do treatment yet. And already you're not having the problem anymore. This is incredible.
That's so cool.
And that's no testament to me or anything. That's just the fact that everybody reacts differently. And when they're armed with a better knowledge and education about what's going on, and they understand how it works, and they're able to put it all in perspective, um, some people get a much quicker reaction than others. So
Yeah,
there's someone who did no exposure therapy.
they're like, yeah, I'm not doing that. I get it.
so
That's
so
awesome.
there is that possibility out there as well.
Yes. Yeah. That's so
Um,
cool.
so so that particular client I worked with online. I actually work with all of my clients online for the most part. What do you do? Do you see clients in the office? Do you see them online? Do you do hybrid?
I just do online right now. So maybe one day in the future I'll do a hybrid type of thing. But for now everything's online and it's been good. It's
Mhm.
been good. So
Have you had any drawbacks or issues or concerns about doing it online, or is it working well?
I will say the only thing that has come up with one of my clients was that they um, had the skin picking
Hmm.
and I couldn't see them. I couldn't see their hands. So it wasn't about till like 6 months in that they told me. And I was like, oh, okay. So, there are drawbacks to it, but it's been it's been a learning experience for me. Like I said, I've been doing this, for a couple of years now. And I just ask more questions. I find myself asking more questions to make sure that I have all the information I need.
Hmm. Good, good.
Yeah.
So last question for you is, if you were to be speaking with someone who was a student or maybe a counselor who just never practiced in the OCD area, and they were considering uh, learning about OCD and adding that into their practice, do you have any particular advice for them? Things to look for or things to run away from?
Um, I think that understanding, that front and back end process, um, and maybe it's just the way I learned, but that really helped me um, understand what was happening with these clients, like what they were experiencing in a clinical sense, so that I could better help them. So whether it would probably be more inference based CBT, like getting their layout just to understand it better. And then, understanding, gosh, what would you say? Like really starting, it's almost a feeling. I feel like you said something like that too, but it's almost a feeling like when you have a client who is, generalized anxiety disorder, but it's really not. You're like, something's not adding up. Um, I mean, I would obviously listen to your intuition on that stuff, but just really understand the difference between, anxiety versus OCD, like, and what that's about. That's going to help you immensely.
Fantastic. Now you're in Virginia, correct?
Yes.
And do you have a listing up on Psychology Today?
Yes, I do. Yep. You
So if
can.
somebody wanted to find you, they could just go to Psychology Today, look for Bernita Oakes, and I'm assuming you're probably the only Bernita Oakes out there.
I am.
All
But
right.
yes.
Well, thank you so much for taking the time out of your schedule to join us today and share this information. I'm sure it will be incredibly invaluable for people who are considering following in your footsteps. And I'm so glad that the OCD community has one more practitioner that we can add in to provide the help for the people out there who really need it. And we'd love to have you back in a future session down the road. So thank you for your time.
Thank you so much for having me.